Thank you, Professor Pesanti. So we will see a little bit how to combine all these concepts in practice. So I have to declare that I am part-time medical research manager for Hamilton Medical. So everybody knows that in RDS patient there is a baby lung, meaning a small aerated lung. But if we ask what causes a baby lung, part of it is, of course, a primary disease, for example, the pneumonia with inflammatory liquid in the alveoli. But we have to admit that part of it is due to the ICU condition, because we have obese patients, as it was well mentioned by Dr. Bera. These patients are in supine position. We use sedation, paralysis. We use controlled mechanical ventilation with no movement of the diaphragm. Fluid overload is very common in the ICU. Some patients have a weight on the chest wall, as it was described by Professor Talmont, and we use high FiO2. And all of these factors combined increase the risk of lung collapse. And this lung collapse that is added by, let's say, the ICU condition is quite easily reversible if we manage it early. And sometimes we realize that when we can reopen or reverse this collapse, actually the primary disease is not that severe. So I think the first step when we get an RDS patient in the ICU is to assess and optimize the hemodynamic. For example, using a cardiac echo, we can see a little bit, is the hypoxemia due to a hemodynamic problem or mainly due to a lung problem? And because we have in mind that maybe we are going to perform recruitment maneuver, it's good to know how is the hemodynamic at the beginning. And then we take a blood gas, and usually, initially, we use a moderate PEEP, let's say from 5 to 10, to assess the severity of the patient. As you know, according to the Berlin definition, we have 3 categories for severity: mild, moderate, and severe. But actually, maybe for practical point of view, we can split the patient in 2, with patient with a PF ratio above 150, and patient with a PF ratio below 150, so mild to moderate and moderate to severe patient, because this recent study show that in terms of recruitable lung, the patient moderate to severe have more recruitable lung than the mild to moderate, and the weight of the lung also is different. So this is how I use in my practice. I will consider open lung strategy only for the moderate to severe patients. Can we use compliance? Now we have on the ventilator the possibility to have an automatic measurement of the compliance breath by breath, but actually the compliance is not related to the severity in terms of blood gas, meaning that there is a lot of overlap between mild, moderate, and severe. However, I think looking at the compliance will inform about the severity of the disease in terms of how small is the baby lung. If we have a patient with a compliance of 20 to 25 milliliters per centimeter of water, we have to think that the baby lung is really small, so there is a high risk of VIDE. After this step, well, I think we have to assess recruitability, because we know from these studies that the amount of potentially recruitable lung is different from patient to patient, that not every patient is the same, and we should not apply the same strategy for every patient. So in order to assess a little bit the patient with low potential and high potential for recruitability, we should start by trying to assess recruitability. Can we predict recruitability? Yes, if we look at the full picture, there are some criteria. We know that severe RDS patients are more recruitable than moderate and mild. The type of RDS also is important. Extra respiratory injury have more potential than respiratory injury, and non-lobar injury on the CT scan or chest X-ray have more potential than lobar. And then the time from the beginning of the disease is important. In early onset RDS, it will be easier to recruit than in late onset RDS. At the bedside, we can also use a tool to assess recruitability, and what I think is quite convenient is to do a low-flow PV curve. So on top of the current setting, we can do a PV curve from 0 to 40 centimeters of water and going down to 0. So the y-axis is pressure, the x-axis is pressure, the y-axis is volume. So the slope of the curve represents the respiratory system compliance at each level of pressure during inflation and deflation. How do we assess recruitability with this? First, we look at the shape of the inflation curve. If the shape has an upward concavity, it means that the compliance increases when we increase pressure. So this patient is very likely to benefit from recruitment. Reversely, if the shape of the inflation has a downward concavity, it means that when we increase pressure, the compliance is decreasing. So this patient probably will not benefit from recruitment. Also, on this PV curve, you can look at the hysteresis. The hysteresis is a surface between inflation and deflation, so all of this surface. Hysteresis is physiological, but in RDS, sometimes the hysteresis is larger than normal, just because there is recruitment occurring during inflation and de-recruitment during deflation. So if we have a very large hysteresis, it means that probably this patient will benefit from recruitment, and reversely, if the hysteresis is very small, this patient probably will not benefit from recruitment. And so at this stage, we can more or less distinguish and decide patients that have a low potential of recruitment, we should not apply a recruitment maneuver, as it was mentioned by Professor Talmor. This will be harmful and totally useless. And because there is no lung to recruit, probably there is no point to set a high PEEP. So we should keep a low PEEP and try to maintain the driving pressure as low as possible because it's a small baby lung. For this patient, we can use prone position. The PV curve will predict if a recruitment maneuver will be efficient, will not predict if the prone position will be efficient. So still, I think we should use prone position. And if the patient remains very severe, we may consider ECMO. Well, how to monitor prone position? Of course, we monitor blood gas, but blood gas almost always improve during prone position by the fact that it improves ventilation perfusion ratio. But then we can also look at the trends of the static compliance along the prone position session. And then you will see several patterns. For example, this patient was prone at this point of time. You see that the respiratory system compliance decreased because when we prone a patient, the chest wall compliance decreased. And then along the subsequent hours, we have an increase in the compliance, suggesting that there was a re-aeration of the lung. And so it's a gradual increase, meaning that probably this patient benefit from a long prone position session. Now look at this patient here. This patient was prone at this point of time, and we saw a rapid increase in the compliance within 2 hours, and then a plateau, meaning that also this patient probably benefit from the prone position in terms of recruitment, but maybe there is no point to prolong the session too much because we reach a plateau. And the third one also decreased the compliance when we prone him, and the compliance did not improve to this point, so we decide that probably prone position was not efficient, and we decide to turn in supine. So now let's speak a little bit about the patient with high potential of recruitment. This patient should benefit from a recruitment maneuver and a PEEP titration to prevent a new collapse. So how to perform a recruitment maneuver? The condition is that the patient should be passive, in stable hemodynamic condition, and we have to overinflate a little bit the curve of the endotracheal tube. There are some contraindications which are very important to respect if we want to avoid adverse effects. There are several methods to perform recruitment maneuvers. What I use in my practice is a sustained inflation method using the same tool where you can set the starting pressure, the PEEP, the top pressure, what pressure you want to reach during the recruitment maneuver, and the end PEEP. Usually after the recruitment maneuver, we increase the PEEP. We can set how fast we want to increase the pressure and how long we want to stay at the top pressure. So the question is what top pressure we should use. We know from studies that the top pressure should be somewhere between 30 and 60 centimeters of water, depending on the severity of the patient and on the chest wall mechanics. Regarding the duration at the top pressure, we show that actually 10 seconds is sufficient to recruit what should be recruited and to prevent the hemodynamic compromise. There is no point to prolong a sustained inflation recruitment maneuver. We only get hemodynamic compromise. And very importantly, the post-recruitment maneuver strategy. How do we set PEEP after the recruitment? If we go back to a low PEEP, all the recruitment will be gone after 10 minutes. So the most important question is how to keep this lung aerated. So this is how you can monitor the recruitment maneuver. Here we perform a recruitment maneuver at 40 centimeters of water for 10 seconds. So you see pressure was increased to 40. And here, this increase in volume is the volume that entered the lung during the 10 seconds. So this is an assessment of how much was re-aerated during the 10 seconds. We are not sure that this is recruitment, but still, if you have a large volume, this is an indication that the recruitment maneuver was quite efficient in terms of volume. Then how to set the PEEP? There are several methods that have been described to set the PEEP. I will not go into detail, but we have to keep in mind that, again, the PEEP after the recruitment maneuver should be between 10 and 25, depending on the weight of the lung and depending on the chest wall mechanics. So how to do in practice? In my practice, I do a decremental PEEP trial, meaning that after the recruitment maneuver, I use a high PEEP, and then I decrease the FiO2 to be in the steep part of the dissociation curve, so to be at a SpO2 between 92–93%. And then I will decrease the PEEP 2 by 2 every 5 minutes, looking both at SpO2, the oxygenation, and the compliance. And when I see a decrease in SpO2 or a decrease in the compliance, this means that the recruitment starts. So let me show you an example. On the upper panel is PEEP. So PEEP was decreased from 20 to 18 to 16, then SpO2 and compliance. So here, when PEEP was decreased from 20 to 18, SpO2 did not change, compliance did not change. Then, at this point of time, when we decreased PEEP from 18 to 16, we saw within a few minutes a small decrease in SpO2 and a decrease in compliance, suggesting that we should not decrease PEEP further or maybe increase a little bit more. To do this, we have to fix the tidal volume because this clinical case shows that when we use the optimal compliance during the decremental PEEP trial, the optimal PEEP depends on the tidal volume. So I think it's good to do this with the tidal volume that we will use afterwards, so usually around 6 meters per kilogram. Well, if the recruitment maneuver, the PEEP titration is enough to improve oxygenation and to decrease FiO2, that's fine. If it's not the case, I suggest to use a transpulmonary pressure to be more precise in the recruitment and the PEEP setting. So this was already mentioned by Professor Talmor that when we apply 40 centimeters of water at everybody, some patients have a very small transpulmonary pressure, probably not enough to recruit the collapsed lung, and a few patients have a too large transpulmonary pressure, probably dangerous for the aerated lung. So the goal would be to target a transpulmonary pressure, I don't know, between 10 and 20 or between 15 and 20 centimeters of water. How can we do this? This is on the top panel, airway pressure, flow, esophageal pressure, and transpulmonary pressure calculated as airway pressure minus esophageal pressure. So in this patient, we apply a recruitment maneuver at 40 centimeters of water for 10 seconds. And then we look at esophageal pressure and transpulmonary pressure. And in this case, transpulmonary pressure was around 20 during the maneuver. You can also display this kind of curve. In this patient, this is airway pressure during the recruitment maneuver. We apply 50 centimeters of water of airway pressure, and we measure a quite large increase in the volume. If we have an esophageal catheter in place, for the same maneuver, we can display the esophageal pressure recruitment maneuver, so the recruitment maneuver of the chest wall, which shows, of course, no recruitment on the chest wall, and the transpulmonary recruitment maneuver, the recruitment maneuver of the lung, showing that all the volume increase, of course, is due to the lung, and showing what was the transpulmonary pressure achieved during the recruitment maneuver, here around 23 centimeters of water. And then after the recruitment maneuver, we can use the transpulmonary pressure to optimize the setting of PEEP, as it was described by Professor Talmor. Again, we can do a decremental PEEP trial, 20, 18, 16 of PEEP, looking at the transpulmonary pressure at the end of expiration. So we have to perform an expiratory occlusion. And at 20, for example, it was 3.1, at 18, 2.6, at 16, 1.7. Usually in my practice, I target somewhere around 2 centimeters of water. Okay, and if using the transpulmonary pressure is not sufficient enough to improve oxygenation, then of course we can prone the patient and go to ECMO. So just to finish and to give you some number, we use this algorithm for several years now, and this is to show you how the patients are distributed in our experience. I look at the last 50 patients that were managed using this protocol, so moderate to severe patient, managed early in early onset RDS. 10 patients had a low potential for recruitability, so did not get a recruitment maneuver, and we prone all of these patients, and out of these 10, 2 had criteria to go to ECMO. One of them had a lot of comorbidity, so we decided not to go to ECMO, and one of them went to ECMO. Most of the patients had a high potential for recruitability. Most of these patients were managed with a recruitment maneuver and a decremental PEEP trial, and we had to use as a second line the transpulmonary pressure in 12 of these patients, and it was quite good for 6 of them. We still had to prone 6 of them, and none of these patients required to use ECMO. So to conclude, lung collapse is not only due to the primary disease, it's also our treatment that worsen lung collapse. Assessing recruitability is a prerequisite for a rational decision about the open lung strategy. And for this, a very easy tool is a low-flow PV curve. We should keep the open lung strategy only for the patient with a high potential for recruitability, which is to perform a recruitment maneuver from 40 to 60 centimeters of water for a short period of time, plus a PEEP titration. In this process, using transpulmonary pressure, I think, is very useful and can improve the understanding for the most severe patient. And finally, all of this, I think, should be an early goal in the management of RDS. Thank you for your attention.